All right.
Okay.
Well, welcome everyone. My name is Mick Hughes, and this is the very first of our the ACL Hub's live Q&A, and I'm absolutely honoured to have a special guest and our very first special guest speaker, Dr. Lynn Snyder Mackler. Lynn, thanks very much for spending some of your evening with us. I understand it's a little bit late where you are, and I'm absolutely grateful that you're coming out of retirement, especially for me and this.
I'm thrilled. Your new content has been great.
I
So it's
appreciate.
been so
Oh,
fun to see the things you've been doing, even on, Instagram or X or
yeah. Oh, that's
other
great.
different platforms.
Well, thank you. It's without your work and other researchers that are producing great ACL research and literature, I certainly wouldn't be able to sort of do some of the things. And your work especially has changed my clinical practice. So I'm absolutely grateful for your time tonight, and hopefully those that are tuning in will be able to benefit from more words of wisdom. Tonight's kind of discussion, I think, given the importance of getting on top of muscle inhibition early and really getting rehab off to a great start, I'd probably wanted to dive a little bit more into open chain exercises and electrical stimulation, and we'll round it out with some of your points of wisdom from your years of experience of working as a clinician and a researcher. And if you've got any pearls that you can share with our listeners, that'll be great. But I'll start with just the sort of well-known, having watched your work and watched you some of the papers that have been published. You've been a very strong advocate for open chain exercises. For those that are a bit unaware of the current landscape, can you give us probably just a snapshot of the research in the open chain literature from what initially was kind of published back in the 90s and maybe 80s and 90s, and how that kind of scared us and clinicians and surgeons away from open chains to where we currently sit with it today? And if you can give us a little rundown, that would be great.
Yeah, sure. I mean, this did not come from physical therapy, nor did it come from any real research. The research that's typically cited is the research from the University of Vermont in that like 80s, 90s, where they put a strain gauge on the anteromedial bundle of the ACL and had people in the OR, get up and do all these different exercises. Those studies, there's a great comparative. They're like a synopsis study by Bruce Bainan and Braden Fleming that has a whole hierarchy of the different things they had people do.
Yes.
And where it falls, but they all fall, 4% strain or less.
Yeah.
And the closed chain, so squatting with a sport cord,
Yeah.
and doing an open chain knee extension with a 30K boot is the same.
Yes.
3.8, right, percent strain. So there's never been any actual evidence that open chain exercise is more strain on the ACL than closed chain.
Yeah.
And to be honest, the most recent studies, which most have come out of Lou DeFreit's lab at Duke University, and they are able to model the ACL as you go through. They use biplanar fluoroscopy, so you really get an accurate measure of
Yes.
how far apart the bones are, right? Their data show that twice in every gait cycle, once in stance, once in swing, the strain on the ACL exceeds 10%.
Wow.
So every
double.
step, more than double.
Yeah.
It's like 11 to 13 actually, but it's triple.
Wow.
So I never have gotten anybody to be able to elucidate why, in fact, this is happening. I have my own. This also led to kind of the demise of isokinetics for a while.
Yes.
Which were, I've lived through all of that and never actually stopped doing those. The problem in the, maybe we chatted about this when we were talking on the phone, but in that transition in that 80s to 90s, um, the placement of the grafts were not anatomic really.
Right.
Often they were quite vertical. So for us, you sometimes had to, the only way you could get extension was to, right, was to stretch them out a little bit.
Yeah.
So concurrent with that was Don Shelbourne's work showing that there are patients who did better were the ones who didn't listen, right? So we're coming out of the immobilization phase, and that led them to more activity earlier and other things like that. That really focused again on ambulation really more than anything else, but closed chain exercise. Although in their group they never gave up open chain either.
Yeah.
But so those two things juxtaposed. I mean, his seminal paper, Shelbourne and Nitz, was published in 1990. That changed practice.
Yeah, and that was like the accelerated rehab process, so to speak, for those those people who are kind of born in the 90s and early 2000s that have only known ACL rehab as it currently sits. Like ACL rehab back in the day was you have an ACL reconstruction, you get put in a long leg plaster cast for 6 weeks. This is 1990s, early 1990s, and in 1994, roughly here in Australia, I remember there was a big shift to all of a sudden now free mobilization.
No more casting, right? So we were about a decade ahead of that, I think. So my first decade in practice, patients were in a long leg cast, including the foot, for the first 4 weeks, bent knee,
wow,
and then at 6 weeks, 4 weeks to 6 weeks, they were switched into a cylinder cast, and that stayed on until 12 weeks.
Gosh.
So you can imagine how awful.
So stiff. How much? What about DVT risk? What was the DVT risks and
I don't know. I have no idea. I can't remember having a single subject have that problem.
Wow.
So. But it was crazy, and of course they came out stiff, quads that legs that looked like this.
Yes.
Around. So it was that rehab was so protracted, and it was really fixing the problem of the protracted immobilization. In 19, this was another changing practice. Frank Noyes, his work, Dr. Frank Noyes, when they presented papers at his like continuing education meeting that he always has around Memorial Day here, so the end of May. And in 1985, they presented and then subsequently published that the patients who you allowed range of motion did way better than the people who were casted, right? Immobilized. And that again changed practice. I think sometimes these studies that are embedded in clinical practice often hit the sweet spot of people are ready for an answer to the question of how can we keep them from being so stiff? That's what happened with Frank. Can't we get them walking earlier or more functional earlier? That was Don Shelbourne's stuff in 1990. So those really just shifted practice. But somewhere in that came this anti-open chain exercise thing, which I'm fine. I understand the surgeons coming in and saying that, it might be stretching my graft, which it wasn't. But I never understood why the PTs fell for it. In fact, people teach it sometimes in curricula. It's like it's malpractice.
And that was my experience for a number of years. It was one of those things taught to me at physio school that if we deal with an ACL reconstruction, so going back to the mid 2000s when I was going through physio school, open chain exercises were advised against strongly, and then my first couple of years of practice as well, there was a constant messaging that the surgeons were saying, and being a young physio, I didn't know any better. I sort of felt like I just had to toe the party line, which kind of then makes me sort of, want to get your thoughts on how do you have any suggestions for those young practitioners? Well, knowing that open chain exercises are helpful and
Yeah.
safe, like you said before, walking, and we encourage walking,
Yes.
up to 3 times greater strain through the ACL. We want people to mobilize. We know it's good for the knee, yet the
Yeah.
ACL is being strained up to 3 times in a simple open chain exercise with a small weight.
Which is clearly not a big deal, right?
No.
As we know, right? For those of us who have measured, even using, arthrometers over the years,
Yes. Yeah.
it's what no one. Well, okay, let's start with tendon and ligament are collagens, right?
Yep.
And they respond strength.
Yes.
Their healing it needs strain. So the absence of strain is never the goal,
No.
and too much strain is never the goal. Yet the 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 goal is to find that sweet spot. And I think contemporary exercises, included open chain, is clearly in that sweet spot.
Yep.
What we've seen over the years, especially with just reliance on open chain exercise, has been this persistence of significant quad deficits,
Yep.
an inability to actually measure what that is. By letting go of the isokinetic dynamometers, we've lost the ability to measure.
Yep.
And we know from every other joint that isolating, or in just strength conditioning, you
Yep.
want to isolate a muscle, you
Yep.
isolate it, right? You
Exactly
don't
right.
use. And the problem with not having that, with having the ability to, or using only open chain, is I can do a very heavy unilateral leg press and
Yep.
not use my quads at all.
Yes. 100%.
So, and I don't, so unless the therapists are checking, they're putting EMG biofeedback on the patient's quads, they have no, or feeling it, watching it, they have no idea.
Yep.
And the more low level that exercise is, like just doing, standing pushbacks, right, with a band or something.
Yep.
You have no idea that they're not just flexing, extending their, slightly flexing and then extending their hip.
Yep. Exactly right.
So we can have our I would say still at University of Delaware at our clinic, we get patients all the time who are referred in. They're somewhere else, but they come to us for testing for return to sport. So they're 6 months post-op, and they come in and they have a 60% quad deficit. We're thinking, what have they been doing with you?
Yep.
The point is they never measured. So hand in glove with this, using open chain exercise starting right away, is measuring.
Yep.
How do you know your strengthening is working? That you have to do. You can do it isometrically. You can do it isokinetically. You can do it with a knee extension machine through the range of motion or partial range of motion if you're a little fearful. But you have to isolate that muscle and find out. And certainly using manual muscle testing is not enough.
Not good enough. That's right.
Not for a big muscle.
With the rise of handheld dynamometry systems, we've got the Vol team have got a great little handheld unit. There's Active Force 2. There's like Lafayette. There's so many affordable isometric handheld dynamometric testing that you can do.
But you can't hold the dynamometer and do that.
No,
it
exactly
has
right.
to be right. It has to be like with a belt or something, or there's you and I would absolutely get different measures on a patient.
Yes. Yep.
Because we'd be testing my strength and your strength, not their strength.
Yep,
So,
exactly. When you've got the hand held on the shin with a device, it has to be.
There's a paper from JOSPT. Oh gosh, quite a few years now. Anthony Stinnecor. So
yes.
SIN, right. So that it was at the University of Pittsburgh, and they tested handheld dynamometer with an orthopedic belt, right, isometrically.
Yep.
They tested isokinetics was the gold standard. Then they did knee extension on a knee extension machine, a 1RM.
Yep.
Through a partial range and full range, and a leg press. And the isokinetic, the leg press and the handheld both overestimated the quad strength.
Yep.
So if you're using those, like for example, we use a 90% cutoff for returning to activity,
Yep.
Beginning to return to sport. You need 100% with those.
Yes.
Because it's not really getting you.
Yep.
So that article is really quite good in showing all the different setups, all the different things you can do.
Yeah, that's awesome. Those that are watching later, I've got a couple of videos I'll share with on the ACL Hub with how you can set it up so you take yourself out of the testing equation. Because one, it's often uncomfortable if you're pressing a handheld unit on the person's shin. You're influencing the results. There's lots of messy data that will come through if you're pushing on the person's shin. You have to set up the system with yourself completely out of it, letting the person do the test on their own. So I'll share those videos with you if you haven't already seen them. That's great insight, Lynn. Thank you. And so just probably thinking about, okay, just ticking off that we know that open chain's safe. We know it's important. It's finding that sweet spot. It's got a nice balance and it fits nicely. But there will still be some young clinicians who are really driven by surgeons' protocols, and those protocols are still, a bit antiquated and outdated, and the surgeon's still anti-open chain. How do you deal with that? Because I get asked this question all the time.
Well, I can tell you a couple ways. You are the one who is speaking for the surgeons, which is something that I've done my whole career. Our group 5 years ago were asked, the American Academy of Orthopedic Surgeons asked us to be part of the development of their online residence curriculum and do the ACL rehab. So guess what's in that ACL rehab? Guess what our residents have been learning for the last 5 years?
Very good.
And also the orthopedic knowledge update, which is done every year or two. Don't quote me on that. But it's the book that residents use to study for their boards, and that surgeons who are taking their requalification every decade use. We did that chapter too.
Excellent.
So so if they look at their own instructional literature, open chain exercises there. So and we've never had a problem. Like I can tell you, I've done this for how many years? 35 years. Something like that. They just need to know that things that sometimes what they were told isn't true. And are you happy? And again, we say send your patients to us and we'll test their quads after you're happy with their rehab at 6 months and tell them they can go back. And then we tell them it's a 60% quad deficit, and they're like, what?
Yeah, the patient won't be happy. I kind of sit well with the fact that I've always thought that the absence of open chain exercise is more harmful than the presence of open chain. And to me, if you find that loading happy loading, respecting if you're having a patella tendon harvest site, which can be a bit irritable with open chain, if the patellofemoral joint's happy, and we can deal with that, and we load lightly and gently to start with, and we then slowly progressively add load. We know that exercise itself isn't harmful. We just have to be respectful, and the presence of that open chain is going to be beneficial, and many studies have shown that. I love the recent work from the French group, Ferrelli and colleagues.
Florian, they didn't say you should do it.
No,
that was not they were very cautious.
Even though the results were overwhelmingly positive for it.
I was surprised. But I was just going to say, you have to really tailor especially your rehab of patients who've had the extensor mechanism used as a graft. You got to remember that graft site, it's a tendon injury, and it's a pretty big tendon injury. the only way back to strain again, the only way that tendon will heal is to provide strain.
Yep.
So it's really incumbent on you to find an angle where you can do isometrics if you can, that is not going to, but also you need to think about using a pain modifying model like they do for tendinopathy.
Yes.
So if it hurts up to 5 out of 10, it's fine.
Yep.
If it's more than that, then you jigger around with it and figure out what. But you don't. Absence of pain is not the goal.
No.
Here for the and then with the quad tendon is exclusively harvested from the rectus.
Yes.
If you do knee extension with the, like I'm right now, sitting up in a chair,
yep.
right? You never strain the rectus. So you have to cheat it back.
Yep.
People wonder why, and what else happens is that tendon lengthens if you don't, right? So they end up with pretty strong isometrically in like 30 to 90, but they have a lag. And they don't have a lag because they're weak. They have a lag because now the tendon extended. It's like Achilles tendon repair when that happens again. You need to provide that work. We have published a couple of papers. My colleague Karen Silbernagel, the tendon expert, right?
Yep.
Our combined PhD student, former PhD student, now Ito, published a paper, a longitudinal study with diagnostic ultrasound, but also shear wave elastography.
Yes.
With the bone, patellar tendon bone, and looking at a month after, 3 months, and then 6 months plus, right?
Yep.
So at the 1 month stage, we've had a central third of the patellar tendon has been removed. The entire tendon is twice the cross-sectional area as the contralateral one, twice, two times. And both the medial and lateral, as well as the central thirds, they're just expanded mostly with this ground substance, right?
Yeah.
So it's ripe for reorganization.
Yes.
And what you see is, as we go along, the central third is lagging behind, but those other sections of that patellar tendon are also sick.
Yep.
So it's got to start to see tension. I know this is another reason why you have to make sure you're putting strain across that.
Absolutely. Yeah. And I've been lucky enough to work with a surgeon here locally in Townsville who, as a unique preference in Australia, to do primary ACL reconstructions with patella tendons. And so I've been working a lot with patella tendons lately for primary rather than kind of like your revisions, which most Australian surgeons will do. And I've absolutely loved the process. I firmly believe that I think previously I was a bit worried with patella tendons and this kind of textbook response that you're going to have anterior knee pain for life. I disagree. I disagree. Yes, they may have some discomfort there for a while, but I think maybe part of the problem is in the past we haven't been loading properly through the open chain exercises and applying that safe, sensible load. I've been treating them like a tendon, like a tendon repair. We hit them isometrically and a little bit of, safe range of movement with some light load. And that tendon and that anterior knee pain at the front tends to deal with it quite happy. And if we have a tolerable amount of pain, somewhere between 2, 3, or 4 out of 10 pain, that's the tough love we need to show these anterior
that's how the
harbor
tendon will
sites.
heal.
Yeah.
Yep. It's really important. And but also the other thing is the bone patellar tendon bone harvest site does not really start to have pain from the tendon until the regrowth of the nerve cells are there. And so it's probably, you're going along just fine. In about 6 weeks, they start to get this.
Yep.
Yeah. So I think one way you can do that is to start with these loads that are, again, we don't start with putting somebody on an isokinetic dynamometer going crazy, right? But what we do is so we haven't talked about electrical stimulation yet, but we dose our electrical stimulation to it be at least 50% of their MVC, which means we put them in the dynamometer at 60 degrees, we test their MVC, and we test it from the first week after surgery.
Yep.
We're having them do MVCs. So it's we are certainly making sure that we're putting load through. Stim has a, neuromuscular electrical stimulation has a double bonus when you're using it in this way. Everybody knows when you put all of the therapists who are looking, when you put electrodes on let's say you're putting it on the wrist extensors, right?
Yep.
You always hit sensory first, right? The largest diameter fiber. So the sensory fibers go. So you're getting that TENS effect every single time you do this, right?
Yep.
So that actually is helpful with the bone patellar tendon bone and quad tendon patients.
Yes, awesome.
As almost a little bit of an analgesic.
A TENS effect for it.
Double.
Yes, no, that's really helpful, and we'll keep rolling through to some of the NMES research. Your early career was certainly dove a lot into that space and showing superiority of adding high intensity. When you say high intensity in terms of a practical nature, is that starting off with that 50% MVC, or are we working higher than that when we work in those
more
first?
is better.
Yep.
So our study, our dose response study was a multi-center study, was in the 90s. We published it in early 90s. And it shows a direct correlation between, right? Absolutely direct correlation. But more is better.
Yes.
You can see that in the rest of the curve, right?
Yep.
But 50% below 50% doesn't seem to have an effect.
Yep, fair enough. And so for some clinicians who may be unfamiliar, so to get that MVC, so for example, if you're testing isometrically, either with a handheld unit or on isokinetic, say they can only generate 100 newtons of effort on in that first week. We're talking about we're talking about 50% as a bare minimum of
as a bare minimum, but I can tell you those people who are very inhibited, we haven't started to talk about inhibition yet, but when your patients who are inhibited, their quad's still waking up.
Yep.
So we often end up dosing them at 2 or 3 times their MVC.
Wow. Yep.
Because they're nowhere near their MVC when they're testing because their quad isn't fully activated. So it's there's no max. And you actually, the quad wakes up and you test them again after, and they're at 300 instead of 100.
Yep.
So it's very synergistic in terms of the way that we've approached this, but they all play into each other. But our goals, you asked me about like in your email, and you talked about it a little bit. What are my real pearls? Is don't skip the basics.
Yes.
Right. So we have these kids come out and they want to do, all these. Don't skip the basics.
Yep.
Range of motion, quad strength. That's your money right there.
Yeah.
So
that's your 99. That's your 99% effort. Yeah.
It's boring. I think I told you we were at the ABTA's combined sections meeting, and we were doing our group we wrote a paper on electrical stimulation that was in JOSPT last year, but also has videos about how we do it exactly, and also how we tested all of these different stimulators to make sure. You have to test your stimulator to see if in fact it has enough juice to actually work. That is also on our University of Delaware clinic website. There's a tab that says for our rehabilitation professionals. It has all of our rehabilitation practice guidelines that we update. You can see when they were updated, and
awesome.
And it's all completely open source. But that video is on there too. We did a symposium. So it was a 3-hour symposium, and there were 5 of us from our group that that wrote this paper that spoke. And so the first question we got, I think I told you this, the first question we got at the end, some people are lined up, and the first question was, so what do you think about, should I add dry needling to this? And I like, I didn't say, were you in this room? But it was like, are you kidding me? And the answer, all I did was lean into the mic and say, no. Next question. Because no, like, do the basics well, and you'll have a tremendous practice.
Yeah, it's remarkable how just by following those those suggestions, as you've already said, how you'll get your patient probably 80% of their recovery in those first 3 months will just happen if you get the range of movement back, which subsequently helps with the swelling, which subsequently helps with fear and fear avoidance, which then helps the quadricep and hamstring and calf and everything else that goes with it. We do open chain exercises and we target the quad, hamstrings if we also too have had a hamstring graft.
Gotta wait for that one though.
What's
Don't do
that?
resisted hamstrings for about 6 weeks.
Yes, correct. Yep.
Because the hamstring growing back, the hamstring tendon growing back depends on it being able to reach the tibia again. And you end up with an unattached muscle, right? The
semitendinosus and gracilis. And what happens when you have them contract, it just pulls up the thigh, up the back of the thigh, and they end up like super feeling like,
and those last forever, right? Those symptoms last forever. So you got to watch out for with hamstring grafts, which I've done a ton of, to let that heal a little bit. And before you do resistant hamstrings. And meanwhile, every paper shows that you don't have the symbiosis between the quadriceps and any intra-articular knee injury is so well documented across everything. Meniscus, OA, every single PCL, ACL. But it doesn't happen with the hamstring. There's not that.
It's strange how it doesn't, but I say this as well, like
it doesn't.
Based on all this work that you've done, is that the quadricep influences knee joint health so much more, and is literally the only muscle in the lower limb that has that profound, significant effect on joint health, and that the hamstrings don't have that same effect. The calf doesn't have that same positive, protective effect, but the quadricep will just reign supreme when we're dealing with knee pathology, any pathology, PFJ pain, patellar tendinopathies, all this extra stuff as well. It's so reliant on a really strong functioning quad.
But when you get to the intra-articular knee injuries, this relationship also is what happens with the quad shutting down, right?
Yes.
So you need to, again, my whole career, I talk about this whenever I do a career type of talk, but this interest for me came from back when I was starting in the 80s. These surgeries were done in hospitals, right? And my patients would come in. They had a patient come in the day before for a meniscectomy. They didn't do partials back then. And they had open meniscectomy. And we do therapy the day before, kind of get them ready, seeing where they were. And then the next day, they come in after the surgery and they can't do a straight leg raise. In fact, some of them, when you ask them to extend to do a straight leg raise, they flex the knee. So it was like, what happened in this hour when you were in the OR, right? That you forgot how to use your quad. And that's what they say. I forgot how to use it. That stimulated the what about using stem in that first to just like reboot the quads. But it's just an interesting set of problems that we have one very good answer for that
Yep. Exactly
that
right.
we should all use. So
Yeah, and the avoidance is just remarkable, but the benefits seen are just so wonderful. But I've also heard you talk about the when it comes to e-stim and electrical
mhm,
stim, the padding, the pads and electrodes that you use, they have to be big,
sizes,
they have to
yeah.
be big, right? Can you
I'm
explain?
going to send you back to that open source article and the video,
Yep,
which is again, um, yes, they need to be bigger.
yep,
Um, basically 3 by 5 inches or 5 by, they could do the math, 9 centimeters, somewhere like that, like this. And
yep,
we have the the proximal pad is on the slightly central lateral side,
yes,
and the distal pad is central medial. And that the electrical field, when you have them placed like that, hits all 4 motor points of the quads.
yep,
So you get them all.
yep. And
Don't stimulate over the femoral nerve. That'll
the,
get your patients will hate it. You won't get it therapeutic.
Yeah, that'll be
Sure.
a nice little tingle they'll get. And for those clinicians who haven't really used electrical stim much, but they're kind of getting
Mm-hmm.
close, clinically, you would assume you would couple it with exercises, and if so, which ones are you preferred? Do you mix both open chain and closed chain, or do you also just use it passively as well?
We never use when we're doing electrical stimulation for strengthening, we never superimpose it on a volitional contraction,
Yep,
and that's because you have no idea what your dose is.
yep,
So, and we haven't talked about this. We do in our clinic, and our labs, we use a burst superimposition technique when we test uh, the MVC where, like, our periodic testing purposes.
yep,
And that is, the patient is kicking out, you superimpose a 10 millisecond supramaximal stimulation
yep,
on that contraction. And what you see is, in most instances, it'll go up, right? So
yep,
that the capacity of that muscle is more than what they can do volitionally.
yep,
That goes down over time, right? As it's the worst early. If it persists, that's another issue.
yep,
Um, but so you have the volitional activation of muscle is um, uh, smallest fibers to the largest, which translates to uh, the slower twitch motor units being activated first, and it going in a very orderly fashion up to the fastest. Electrical stimulation, you have the pads on the thigh, so they're going to stimulate the the motor nerves, the little branches of the motor nerves that are under that in that electrical field,
yep,
and those will be stimulated from the least resistance is the largest diameter fibers, which are sensory, and then the motor neurons that go to um, the largest diameter fibers that go to the faster twitch motor
yep,
units. It's not direct reversal because
yep,
just think about, if you thought about the quads as from the surface as like a square, it's the electrical field. There will be smaller diameter nerve fibers that are closer to the electrical field that'll happen before larger, but in general, it's
yep,
going to bias those motor units that don't get activated when you have inhibition.
yes,
So when we do a test where someone has full activation, instead of I'll go this way because it's going to look like, instead of it going, you go up to here, they're going across, and then you add the stim and it goes up.
yep,
you add the stim and it goes down.
Right.
And it goes down because nerves, nerves, nerves are just wires. So when you put
Yes.
an electrical impulse on the thigh, it goes down to where you want it to. It goes to the muscle,
Yep.
but it also goes back to the brain.
Yep.
And so what happens when you have full activation is those are colliding with each other.
Yes.
And you don't really want that to happen.
No.
So if you're looking for, I mean, you don't want to so you actually make it go lower. So when you're doing stim, not functional electrical stimulation, we're trying to get them through emotion or working in those kinds of manners. But when you're doing, strengthening, the evidence is do it. You called it passively. It's not really passive, but
Yep.
without not superimposed on a volitional contraction.
Yes. Okay. Makes sense. That's good. That's very, very good. That's helpful too. Because I think there'd be some people who try and couple it and do.
Oh, lots of people do. That's
Yeah.
the number one question we get now.
Oh, very. Excellent. Well, we're getting through. So we've ticked off open chain exercises. They're safe and effective. Oh, just for summary with open chain, you would comfortably start from day one in a comfortable.
Yes. Yeah, I mean, you're going to start with, we'll start with long arc quads and then add weight that as that week goes on, really,
Yep.
that they can tolerate. I mean, you're not going to just blast them, right?
No.
You're going to see what they can tolerate, and then you get into a regular program of progressive resistive exercise.
Yep.
You're going to add, you're going to use whatever, strengthening. Not early on. Early on, you're going to do a little bit more reps, lower weight, but
Yep.
then you're going to start to get into the real strengthening paradigm of 6 to 8 reps with as much as 10 rep max or 6 rep max or whatever it is.
Yeah.
But again, on our UDPT clinic, I'll tell you have to put in there, or udpt.edu. You get to the clinic, there'll be a clinic button, and then you get to the clinic and go to rehab professionals. And our ACL practice guidelines have all of the stuff that I talked about. It is pictures of everything. It has, it also has how the electrical stim is set up. It really, and all modifications for different grafts. And it has a nice table that looks at the progression of open chain exercise through the
Perfect.
the beginning of therapy. So you're
Perfect.
more than welcome. Again, it's open access. Just give us, site or your UDPT and feel free to use it.
Yes, excellent. I know that
And
paper
show
very
your-
well. I've shared it many, many times, and it's certainly something that I've got on the speed dial, so to speak. You might
Yeah.
the clinical.
But so you have the paper is great because it explains everything, but
Yep.
the practice guidelines are just much more extensive in terms
Yep.
of for the therapist, right? It's
Yep.
got all
Exactly right.
kinds of instructions.
Perfect. And
Hopefully
then
that helps.
no, it does. It does a lot, and I'll share those resources and the links with our listeners too. So open chain, safe and effective. Electrical stim is very helpful. All the big, these 99 percenters, I call them 99 percenters. These aren't 1 percenters. These are the things that it should be your bread and butter, basic stuff that's implemented from day one, and our patients will just continue to get great outcomes if we just stick to these big rocks and your blood flow restrictions and your dry needling and all the other passive interventions or other interventions you want to throw at it. They literally are luxury items that really should be sort of reserved if done at all.
Yeah,
to be honest.
I'm really at a loss over dry needling for this particular population. Blood flow restriction. There was a wonderful one of my group that I collaborate with at the University of Kentucky. Brian Noren is the lead author. They
Yes.
had a paper in Medicine, Science, and Sports and Exercise, a report from their randomized clinical trials, NOEHREN.
Yep.
Brian from the University of Kentucky, and they did a very well designed NIH funded randomized clinical trial
Yep.
that added blood flow restriction to this kind of a rehab program that I'm talking about, right?
Yeah. Yep.
And they did muscle biopsies, serial muscle biopsies. They had the physiology, they had the strengthening. There was no other benefit.
Mm.
And in my clinical experience, and in years ago, I mean, we used to do these. They would do clamping studies, which is essentially this: you cut off the blood flow, and
Yeah.
there's really good physiological reasons why this should work, and good studies in healthy muscle. But what seems to be coming out is that if the patients can't volitionally exercise at a high enough intensity,
Yep.
then blood flow restriction may have a place. And again, we have that in our practice guidelines. You might add this if
Yes.
your patients are having a hard time,
Yes.
right? And we do functional electrical stimulation then too, right?
Yes.
I'd add that for their straight leg raise. That's not part of my NMES for strengthening,
Yep.
but it's another tool in my box. The other thing is you might use EMG biofeedback
Yes.
at the same
Yes.
time. One of the, not at the same time, but in a similar manner to
Yep.
try and get them to be able to activate the quads more.
Yep.
And there are people who have persistent activation failure, and that's how do you approach that? There's
Yeah.
pre-therapy, cryotherapy has a little bit of evidence. STEM and biofeedback probably have the so we don't wait for that, right? We start
No.
the STEM day one because it's like most of the people are going to have some sort of activation failure. So let's just wake up that quad right away.
Yeah, let's get straight into it. And the longer that it takes for you to sort of start diving into some targeted quad work and electrical stim, what other things you're going to throw, if that's delayed, every week delay is just going to be harder and harder to turn back on, so to speak. So day one, get into it.
Mick, you also brought up a really good point that active range of motion is one of the best cures for persistent effusion.
Yes.
Get that knee moving and that fluid will move.
Oh.
Right. And too much weight bearing
Yep.
can often be a cause.
Yes.
Right.
Yep.
So if you're doing too much weight bearing exercise, that loading itself, joint loading, may be contributing to a persistent effusion. So, we have, think about it, you probably have the same thing. You have kids who are in high school or something, right?
Yep.
And they have an ACL injury, and the first few weeks, they're doing fine, and then you get them walking without their crutches, and then one day, a couple days, you saw them on Monday, they come in on Wednesday, and all of a sudden they have a 2+ effusion.
Yeah.
And you're like, wow, what happened? Trying to figure it out. And often for us, they have a pass from their doctor that they can use the elevator at school or have longer time to get to class. And then after 3 weeks, it's like, you don't need that anymore. They don't get it again. And then all of a sudden they're doing all this, trying to get from one place to another, up 3 flights of stairs in 2 minutes.
Yeah.
And so you have to query them about weight bearing activity outside of therapy, not just in therapy. But if you've added a ton of weight bearing exercises, and the next day they're a little bit more swollen. So every therapist needs to know how to do a sweep test.
Yes. Yes.
And grade effusion. It's so easy. I teach my patients to do it.
Yes.
They can do it themselves. It's super easy. They can do it on their own.
Yep. As long as they know what they're looking for and you teach them, they can just have that daily check-in. I strongly advocate for a stationary exercise bike from as early as they can turn their legs over on the bike. Once they can bend to 100 degrees, that's going to be our preferred, range of movement / effusion control exercise for the next, few weeks until we can start tolerating load more. So, it's super important and so helpful for a lot of things. We're getting pretty close to the end, Lynn. I've taken a lot of your time. Let's sort of now probably dive into some deeper words of wisdom. I think you've been around for a while and seen a lot of
Yes,
things
sir.
come and go. Where do you think the next
Yep.
5 to 10 years of ACL literature is going to take us
Well,
from what you've seen?
You had some questions that you were going to ask and talk about the like neurocognitive stuff.
Yes.
So I'm going to keep beating the quad
Yeah.
thing. If you look at Dusty Grahams has really wonderful work in this
Yeah.
area. And one of his graduate students, either last year or the year before, they have a paper that shows if your quads get strong early, you don't have those changes in your brain. So guess what? We're failing them, right? Because they don't have to figure it. Maybe they don't have to figure it out.
Yeah.
We talk about this periodically. I'm going to see him in a week, and we'll see what's the next stuff that's coming out. But getting strong quads early,
Yeah.
seems to be protective of that remapping of the brain.
Yes.
So get their quads strong.
Yeah.
But I think, there's a lot of work in that area that, again, the way we've been able to function or be our name in our clinic is we'll take these folks who haven't been well rehab and then help them get to where they need to be. But again, by measuring them and figuring out what's going on,
Yep.
I would say, I mean, I want to not say there's going to be a new thing. I hope there's going to be a return to the basics.
Yes.
And that people are going to say, if I get them here, like if I have a patient, I see them pre-op, I tell them to do when they come out of, as soon as they get out of their OR, out of the OR, to do, supine wall slides.
Yep.
And towel stretch, right, to get extension.
Yep.
And then they come in, and the next couple of treatments, you've got them to 110 degrees of flexion. They have a good straight leg raise, maybe not a great one, but a good one.
Yep.
You won already.
Yep.
Right.
Yep. Yep.
Already won. So that's what I wish for. It would be my legacy wish is that don't go chasing crazy stuff.
Yep.
Do the basics well for ACLs. I mean, yes. I think for everything else too, but for ACLs, we know we have a formula, right? So our practice guidelines, when I talk to groups about this, it's a recipe, right? There are lots of ways to make a chocolate cake.
Yes.
Your grandmother has one, my grandmother has one, right? Whatever. It's the same thing here. So the way ours are set up these are guidelines and then milestones. And
Yep.
if your patients are meeting those milestones, keep doing what you're doing.
Yep.
But if they're not, here's a nice recipe to get you there.
Yes.
Right. But don't forget to measure. So
yes.
I don't know. I mean, I know it's boring. I'm sorry, I don't have
No, it's refreshing, and I think it's important because a lot of the students who listen to this and early career physios who listen to this stuff, they are kind of overwhelmed with what is currently available with the rise of social media, YouTube, and influencers. There is a lot of stuff there that there's
some wacko Instagrams out there with what their patients doing. So one other thing, you brought up fear avoidance or kinesiophobia. It depends. So I think about kinesiophobia very early in the process where they're afraid to move.
Yes.
And then the later fear avoidance of being fearful of getting back to play.
Yeah.
Right. But when you look, not so much the early one, but the later one, like ACL RSI or other measures like that.
Yep.
If you almost always the group that has the worst score are people who, if you ask them, will say because of factors relating to my knee, like swelling, pain, weakness, lack of range of motion. So I still think the best way we can get them to feel prepared to return
Yep.
is a systematic increase in what we do, getting the range back, getting rid of the swelling, paying attention to effusion as a gauge. I mean, I think the two things we use for effusion for gauging progression in our group is soreness, knee soreness,
Yes.
not quad soreness, or even patellar tendon soreness. We're okay with that.
Yep.
Joint soreness and effusion.
Yep.
Those go up. It's bad. It's
Yep.
a bad thing. So you've gotta adjust for that. So I think, I don't know. I think it's just, you can get a lot of reward out of just doing boring, normal stuff with your patients. You
Yeah.
see them progress so much faster
Yeah.
and better.
I love it. And I sort of take pride in the fact that often when a person comes to see me, I give them just probably no more than 5 exercises. Generally, it's only 2 or 3.
Mhm.
It's always a knee extension. It's always, a complementary closed chain exercise.
Yeah.
And generally, as they're moving along, it's a progression in their jumping and landing sort of habits.
Yeah.
And, if they've got extra time to do things, then we throw some extra sprinkles on top. And I measure every session, every fortnight, every 2 weeks or 4 weeks. I'm remeasuring, I'm testing, I'm gathering, their progressions and using that to motivate them. And it's just such a simple process. And I sort of look at some other clinicians doing things, and there's just so much complicated programming and not to say that I'm doing the best job in the whole entire world, but I just find that consistency of measuring, addressing the impairment that I'm seeing when I measure, and progressing rehab, and then testing again. And the testing always seems to be that little bit better than last time. So it seems like it's doing a good job.
And I think we have solutions for being able to test even if you don't have the most fancy equipment.
Yeah, exactly. Well, I like that answer. I think it's, the next 5 to 10 years would be nice for people just to return back to basics, is what I've just heard there.
Well, because we've lost that. I mean, what we're seeing is our patients are not strong at 6 months. They're just not. So what's missing? Why aren't we getting that?
Exactly right. So that probably feeds into the common mistakes, which would be my next question. So it sounds like there's probably, if you read between the lines, there's a few common mistakes that clinicians make, being the absence of open chain, I'm assuming, would be part of your response.
I would say, and I say, even if they aren't doing open chain, if they aren't measuring, they don't know that the patients are concerned.
Yep.
So I would say not measuring is number one.
Yep.
But just like you measure range of motion, you have to measure that. And that is isolating the quad and getting an idea of where they are. And then, I mean, I think STEM is imperative because of the prevalence of quad inhibition or whatever, arthropenic muscle inhibition in the early stages, very early stages. You can really wake up that quad with STEM early. And open chain exercise, making sure you don't. But I don't want to discount making sure that they're, I mean, like I said, the 2 exercises I give them usually right before surgery are supine wall slides, which is going to concentrate more on flexion, but it is active motion, so it will help. And their foot's elevated, right? So it'll help with effusion, it'll help with range. And then a towel stretch into hyperextension.
Yes.
So you can't forget that, and that's something they need to do every day.
Yeah.
Whether they're seeing you or not, they have to get that range back.
Yep.
So
very good.
Again, boring.
I'm all about boring, Lynn. You're singing, you're preaching to the choir here, but I love it. And I think the more people that can sort of hear this beautifully boring approach, then the world will be a better place. All right, last question before we go, and I'll let you go and have some dinner or go have an early night. One piece.
What time is it? It is 5 minutes to 8 p.m.
Oh, so, there you go. There you go.
Yeah, okay.
One piece of advice or key message to early career physios who are managing ACLs, what would that be?
Well, that's a good question. Make sure you're on top of what you should be doing, right? Don't get bogged down. And again, I'd be back to the please get range of motion back, get their quads firing, get their effusion down,
Yep.
and after you're going to win if you do that. You don't need to be doing all kinds of fancy, like again, the Instagram stuff cracks me up sometimes.
Yep.
But I'm not saying there's not good stuff on there. There is. Saying there's some stuff out there where people look like they're frenetically going back and forth doing, I don't know, hitting the ladder drills or whatever when they're,
Yep.
you know, they have an effusion and they can't even walk right.
Yes.
So think about it being progressive, and like think about what they can do at home. Again, not overloading them with home exercises, but
Yep.
what's the biggest bang for the buck for them? Early, middle, and late, right?
Yep. Yep, amazing. And I think that's a key message is that, you know, whatever you do in the clinic, you may only get to see them 2 or 3 times a week, and at best you're only going to see them at best you'll see them for an hour. Most clinics here in Australia, you'll be lucky to see your patient for more than 30 minutes. So what is that patient doing, especially in that first month post-operatively where things are sore and swollen and they're dealing with that site pain? What are they doing for those extra 4 days per week outside of that face-to-face? And that's assuming that you are lucky enough to get 3 sessions a week with them for the first 4 weeks, which once again is probably a bit of a rarity here in Australia. So yeah, it's important to think about what are they going to go home with and what is going to be their best bang for buck exercise. And of course, you know, we've talked about that a lot today. So Lynn, you've been absolutely wonderful, and I've always learned something new when I talk to you, and I really appreciate your time tonight. And our listeners, no doubt, would also learn a whole lot. I'll be posting and linking the resources you mentioned, so everyone can sort of see them and share them and get to improve their ACL rehab. But yeah, I can't thank you enough, Lynn. I really appreciate tonight.
Well, I really appreciate the forum inviting me, and I always love having these discussions.
Very good.
This is, you know, from my you know, this 40-year quest into why quads don't work after knee surgery is we're getting some answers. So
yes,
I feel like we at least have some therapeutic answers from the PT side.
Exactly.
Be successful.
Well,
Thank you very much.
Forever grateful. All right, Lynn. Well, have a good night and enjoy
You too.
enjoy your travels and some more of
I
your
will.
retirement. We'll cross paths again soon. Thanks.
Terrific. Thank you.